Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. This is Dr. Andy Cutler, and today we have a very important and a topic that we probably don't learn enough about. And with me today is an old friend and really the perfect person to talk about this, the acknowledged expert on this topic. We're talking about body dysmorphic disorder, and with me is Dr. Katharine Phillips, who is at the Weill Cornell Medical College and at the York-Presbyterian Hospital. Katharine, how are you?
Oh, I'm doing well, and I'm so happy to be here. I'm so thrilled. Thank you so much for inviting me.
Well, thank you. We have a rather broad clinical audience and maybe some lay people. And so let's not assume that everybody knows all about this. And let's start with the basics. Maybe you could give us a brief definition and overview of body dysmorphic disorder.
Sure. So body dysmorphic disorder, known as BDD, is a pretty common but very under-recognized disorder. And these are people who worry that there's something wrong with how they look, that their skin is terribly scarred, their jawline isn't at the right angle, their nose is the wrong shape or size, when in fact they look entirely normal. They often will say they look ugly. Some use milder terms like unattractive, others more extreme terms look like I look like a monster. And in reality, they are entirely normal looking, and many are quite attractive. So they have very distorted body image. And then in addition, they're preoccupied with this. They think about it a lot. The thoughts keep coming into their mind. They're hard to control those thoughts. And then to differentiate body dysmorphic disorder from sort of very common appearance concerns that most people have, it's required that the person experience significant distress or impairment in functioning as a result of these preoccupations. Again, to help us differentiate problematic focus on perceived defects in appearance from more normal, run-of-the-mill body image concerns that I think most people have. And then one other little piece of the definition, which is important because it can often be a clue to the presence of BDD, sort of something to watch out for, is the repetitive behaviors. We often call them compulsions or rituals. So the thoughts that I look ugly or my hair looks, terrible and, really, really unattractive, triggers the desire to check or fix or hide, what the person doesn't like. So things like compulsive mirror checking or excessive grooming or reassurance seeking. How do I look? Do I look okay? These kinds of repetitive behaviors are part of the definition and can be sort of a clue that someone may have the disorder.
Yeah, boy, what you're describing sounds a lot like OCD or a variant of OCD. Mm-hmm. What's the relationship there?
Well, that's a great question. It does, BDD and OCD have some overlaps clinically and genetically also, but also some important differences. So, they both are characterized by obsessive thoughts, and the obsessive thoughts sort of trigger those repetitive behaviors, things like hand washing in OCD and excessive mirror checking in BDD. But there are a number of important differences. I think maybe the most important one is that there are higher rates of suicidality in BDD. The rates of suicidal ideation, suicide attempts are very high in BDD, and many studies have shown, significantly higher than in OCD. And BDD is characterized by much poorer insight. So most people with BDD think it's probably or definitely true that they look abnormal or ugly in some way. Whereas people with OCD are more likely to realize that the beliefs that underlie their obsessions are not true. For example, will the house really burn down if you don't check the stove 30 times before you leave the house? Most people with OCD say, well, I worry about it, but no, probably not. And comorbidity is different. I think, BDD is more often comorbid with major depressive disorder, substance use disorder. So those are just some of the differences. And interesting, this is great. Big twin studies have shown that BDD is partially genetically determined, which shouldn't surprise us, like other psychiatric conditions, but there is some genetic overlap with OCD and some differences. So some shared genes and some unique genes, although we don't know exactly which genes those are. So I think another reason it's important to differentiate the disorders is that the medication treatment of BDD is pretty similar to that for OCD, but the cognitive behavioral therapy, our first-line psychotherapy, has some important differences. So I think sometimes clinicians may treat BDD as if it's OCD, and it doesn't always go that well.
Right.
If that's done.
Right. Well, that is extremely helpful and certainly a little bit eye-opening for me, Katharine, and I'm sure for our audience. And again, extremely practical information. For our clinicians out there who now are a little bit alerted to this and want to look for it, are there some subtler signs or red flags during an evaluation that might help you with this?
Sure, yes. I think those repetitive behaviors can be a clue. If your patient is stuck in the bathroom and is late for your appointment, or the family says they're in the bathroom a lot, you don't want to assume it's OCD and that they're washing their hands, right? It might be BDD, and they're checking the mirror and trying to get their hair to look right, or trying to get some little pimple off their skin. Of course, there could be another explanation as well. But I think the rituals, can be outward manifestations of this disorder. Social anxiety and social avoidance, very important aspect of BDD, because if you think you look ugly or abnormal and you think other people agree with you, then you're going to feel anxious in social situations. And so sometimes it's misdiagnosed as social anxiety disorder, but of course, or agoraphobia. But of course, if someone is reluctant to go out of the house, we always want to ask, what's making you anxious, or why don't you want to go out? And I would even take it one step further and say something like, some people don't go out because they're worried something's wrong with how they look, about their appearance. Is that a problem for you? I think also, if someone has, sort of persistent treatment-resistant depression that's not responding to standard treatments, you always want to think about BDD, or, something else that may be triggering the depression. And of course, you can always ask directly about BDD, which is a very good idea because it is a pretty common disorder. It's more common than OCD. It's more common than anorexia or schizophrenia or many other disorders. Yeah, currently affecting about 2 to 3% of the population, although I suspect that it's more than that because we haven't had a good prevalence study in a long time. But we don't know that for sure.
Well, it's probably a bit of a hidden epidemic, I would think, too.
I think so. I think so, yes. And it's easy to miss it clinically because the patients are often embarrassed and ashamed, and they worry that you're going to think they're vain, which they're not, or that this is a silly concern because they look great or they look fine, and they don't want to draw more attention by talking about whatever it is they don't like about how they look. So it's often, I think, a hidden disorder, and multiple studies have shown that it's usually missed in clinical practice. So, it is important to screen patients for it. It's out there.
Right. Well, that's why I'm glad we're doing this podcast. And, I think you made a very important point for the audience, and that is, don't assume when you hear somebody's not going out socially or they're anxious. Don't assume you know why. I think it's really important. I've always said, Katharine, to be a good clinician is to be curious and just ask more questions.
Yes.
Yeah.
Yes.
And if
absolutely.
we understand the motivation, what's driving it, or what the concern is, I think then, yes, it's important because it informs treatment, So that's very important.
Definitely. Yeah. Yeah.
You're also reminding me a little bit of binge eating disorder because I did one of the clinical trials for lisdexamfetamine, and I remember when I looked for it, my goodness, I was surprised how common it was and how embarrassed people were and how they kind of hid it and they suffered with it. So certainly not saying this is the same thing as, but there are some analogies. And I think we've done a good job educating a little more around binge eating disorder. I think it's higher top of mind, but this one, not so much. Or not as much.
Yes, I agree.
Yeah. Well, you certainly talked about some of the comorbidities, which I think is extremely helpful. And you've talked about the differences. I'm very curious, though, what you're describing just sounds to me like it might be more common in women. Is that true, and are there other differences that we should know about? Age groups, gender, such?
Okay. Yeah, I think a lot of people assume it's, affects mostly women, and there's a slight preponderance of women in adults, but it affects maybe 40% male, 60% female among adult samples.
Okay.
Yeah, a lot of men.
Helpful. Yeah.
And boys and men. And but among youth, children, adolescents, they're affects more females than males. So possibly a little bit, later onset for males. But yeah, we have to keep in mind that a lot of men are affected by body dysmorphic disorder. And, there's one form that afflicts mostly boys and men, which is muscle dysmorphia form of BDD, which they think they look puny or not muscular enough, or their body build's too tiny, and in reality they look normal or sometimes abnormally muscular, actually muscular, because, about 20 to 40% of those with muscle dysmorphia use anabolic steroids, potentially dangerous, really quite risky drugs, that build muscle, but that can also cause psychiatric symptoms like depression and suicidal ideation when you're coming off of them. People can become physically dependent on them. And roid rage, our listeners have probably heard of, where they can become quite aggressive, and many medical risks also, increased risk of heart disease and other things. So that's a form of BDD that affects, primarily males. It usually starts during adolescence. So if there are people, listening who work with youth or have kids themselves, it's something to be aware of is that in about 2/3 of cases, BDD onsets before the age of 18. And the most common age of onset is 12 to 13. So, I think one of the challenges there, it's easy to kind of dismiss it as just a phase of a normal phase of adolescence, right? And so I think it gets especially missed in the younger people. And that's where it's really important to think about, the definition and, is it causing quote unquote clinically significant distress, or are the body image concerns interfering to at least a moderate degree with day-to-day functioning? Is the child late for school because they're trying to comb their hair for a few hours in the morning, get their hair just right, or stuck in the mirror, or don't want to go to school because, they're afraid people are going to laugh at them or make fun of them because of the shape of their face or something like that. And, we don't want to assume that all body image concerns in adolescence are just normal in a passing phase. So.
Right. Well, this has all been also extremely helpful. And again, the analogy with binge eating disorder, people are surprised how many men can have it too. And I think the breakdown is similar to what you said. I think it's about 60-40. So that's important. And it certainly makes sense that maybe it's coming on a little later. There's a lot of, obviously, social and peer pressure on appearance with girls.
Yes.
And I'm wondering about the effect of social media. I can only imagine it has not been a good thing for this.
Probably not. There are quite a few studies showing that use of image-centric social media that focuses on how people look is associated. Most of the studies are cross-sectional, but some longitudinal studies suggesting, that certain forms of social media, not all forms, of course, may be linked to an increase in body image concerns. Now, that's not the same as the disorder BDD, right? But some overlap. Studies in BDD are just a few and small cross-sectional studies suggesting a link, between body dysmorphic disorder and use of certain forms of social media. I'm trying to remember what they were, Snapchat or Facebook or something like that. That association, as you know, doesn't imply causality. And we don't know, from cross-sectional studies, is use of certain forms of social media a risk factor for developing BDD? Or are people with BDD more likely to use these forms of social media and edit their photos more and that sort of thing? Such an important question, though. We know that BDD is is maybe 40% genetically determined. So and we know BDD has been described since the 1800s, and I'm sure existed long before that. So, we can't say that social media is the cause of BDD, right? It's been around for a long time. We know it's multifactorial in terms of its cause. But I do wonder, is the use of certain forms of social media and being, seeing such unrealistic images online of what people look like, morphed, photoshopped images, all the cosmetic surgery that people are having, et cetera. We see increasingly these sort of unrealistic ideals online, and young people are seeing a lot of that. And it does make sense to me that, certain forms of social media are one more risk factor for the development of BDD. And you wonder if someone's sort of genetically predisposed and perhaps has other environmental risk factors, might this, certain use of certain types of social media just kind of push them over the edge into the disorder and to developing the disorder. I think it's very possible, and I wouldn't be surprised if BDD is becoming more common more prevalent for this reason.
Yeah, it certainly makes sense. I know I've seen Instagram and TikTok be on the rise, and certainly those are visual.
Yes.
And what I've noticed too, I see a lot of younger people taking selfie pictures and selfie videos with these really exaggerated postures and poses.
Yes.
Almost
I see it all over New York City.
Yes, of course. So,
yes.
But again, that doesn't mean they all have this condition. But I like your analogy.
No.
I've said for years, a lot of people smoke cigarettes, they don't all develop lung cancer. So maybe there's a genetic or other predisposition.
Yes.
And I also like your concept of, it's not just the behaviors, if you will. You've got to have impairment or distress, significant impairment or distress. Yes. That's true, again, for virtually all of the DSM disorders. Mm-hmm. There's obviously a continuum of these kinds of symptoms and behaviors from normal to pathological. Moving on, let's talk a little bit about treatment. So you mentioned pharmacologic therapies, and of course you mentioned CBT. Let us start with the various evidence-based pharmacological interventions.
Yes. It's really wonderful. When I started my work in this area, like in the early 90s, we had no treatment. And BDD was not known. It's still under-recognized, but it's definitely gotten better known. And a lot of people thought, this is just vanity. And it was dismissed. We know now that it's a brain-based disorder. There's a genetic component. And I think the best news is we have really good treatment. So one is medication. The treatment is very similar to that for OCD. SSRIs are our first line. And we have multiple studies, showing that they are efficacious. We often need higher doses than we might typically use for depression or some of the anxiety disorders. So that's important. It's like OCD. I think they're often underdosed.
Yes,
right?
I was absolutely going to ask that question. Yes.
Yeah. So, we don't have nice dose-finding studies in BDD where people are randomized to different doses. So, but and to back this up, but just based on a lot of clinical experience and sort of expert consensus in the field, I adhere to the American Psychiatric Association's practice guideline on OCD for the maximum doses that I sometimes use. So 120 of fluoxetine Prozac, up to 400 of sertraline, up to 60 of escitalopram with EKGs at 30 or 40 or higher. I don't use too much of fluvoxamine, but you go up to 400, 450 if you need to. Paroxetine, I don't use much, but you can go up to 100. So these are they're high doses, but they are kind of backed up by the APA practice guideline for OCD. So I don't feel that they're that, I feel that they're fine, and they're also backed up by an international consensus paper on the treatment of BDD that was published in 2021. David Castle is the first author. I think it was on behalf of the ECNP organization, actually. The only way in which I don't follow the APA practice guideline for OCD, because it hasn't been updated for a while, is I don't use citalopram anymore, because I used it a lot and it was fine. People did great with it, but I think because the FDA revised that maximum dose downward a while ago to 40 a day, and that's just not high enough for so many patients. And, there is the risk of cardiac arrhythmias at higher doses. And plus we have escitalopram, which is pretty much the same.
Well, but may have less cardiac toxicity, so that makes sense.
Yes, exactly. That's right. Yes, thank you for pointing that out.
Well, may I ask you another question? I would think the titration is important, too, and that you want to take your time there. I can imagine these people would be sensitive to side effects. Or not necessarily.
No, if they're younger than, if they're under 18, I'll start with, half the usual dose. Or if they have a history of sensitivity to medication, yes, I'll start lower, or history of panic attacks, I'll start lower. But otherwise, I'll start at 20 a day of fluoxetine, for example, and I'll increase by 20 milligrams every few weeks, up to 80 a day, and then I'll just leave it there for a little while. Of course, if they start getting better at a lower dose, I'll hold it there longer and see how they do. But I'll give them a good 3 to 4 month trial with, at least maybe 4 to 6 weeks at those maximum doses. Actually the manufacturer's maximum dose. So maybe like 80 for fluoxetine, 200 for sertraline. And I'll just keep them there, for a full 3 to 4 month trial since the beginning. But maybe 30 for escitalopram as opposed to the usual 20 that people might go up to. And then if they're not, doing well, not fully remitted, and they, and I usually increase those doses further, slowly, gradually, up to those maximums I mentioned a few minutes ago. And, you can also augment, of course. We have very little data on SRI augmentation, but I published a little bit of data on buspirone, which I like a lot. Yeah, I think it's an underappreciated medication because I think the dosing's often too low, right? And it can certainly help anxiety as an augmentation agent. It can help depression. I found that at an average dose of 50 to 60 milligrams a day, it can help BDD, obsessions, preoccupations. And then, of course, we have the atypicals and very little data. But again, we have international consensus from the clinical experience of experts in the pharmacotherapy of BDD, indicating that atypicals can certainly be helpful. I really kind of prefer aripiprazole, but there are others, of course, that can be used as well. I did a small study on pimozide augmentation of fluoxetine a long time ago because it's you probably remember this from the 80s. It had this reputation as being uniquely effective for monosymptomatic hypochondriacal psychosis, if you remember that, sort of the somatic delusions, and BDD has no insight, often delusional beliefs. But that study was so negative. And of course, now the combination of pimozide and an SSRI is contraindicated. It was when I did the study, but now it is because of the risk of cardiac arrhythmia. So I go with the atypical sometimes if I need to, but they are our first line SRI augmentation strategy in OCD, and there are so many similarities between BDD and OCD, and we often prefer aripiprazole also in OCD as an SRI augmentation agent if we're going to use an atypical. And I find it can be helpful, and if we need to add it, and occasionally I add it at the beginning of the SRI trial. If patients are very ill, and especially if I'm worried about their safety, or they have very severe depression, I sometimes will add it early on and not wait for a full SSRI trial to see how the patient's going to do with that.
Right. How about any evidence for lithium or thyroid hormone augmentation?
Well, no evidence really. Maybe I think I published a paper a long time ago saying, in some cases, lithium works. I can remember a few very ill patients I treated who did well with lithium, but I can't say I've used it much. We, for BDD, we tend to take our clues from OCD world, because there's so much more pharmacotherapy data in OCD, dramatically more than for BDD. And so, we wouldn't use lithium usually for OCD either. So I think if there are other reasons to use it, I mean, it certainly can allow us to treat someone with comorbid bipolar disorder, right? Get them on a mood stabilizer first, maybe an atypical, maybe also lithium, if they've had very severe manic episodes. But otherwise, I tend not to use it for this disorder. And thyroid hormone, no data on thyroid hormone at all.
There is a literature of using those as augmentation for unipolar MDD as well. But
yes.
What's prompted my question was when you were talking about the high suicide rates, lithium does have some anti-suicidal evidence. So, okay, any other, I mean, that's
as do the SSRIs,
range.
Right?
Yes, that's
the
true.
SSRIs
Of course. Well, I think effective treatment of the underlying illness probably helps with that.
Yes.
Of course.
Yes, definitely.
All right. Other well, I have to ask you this. I get asked this all the time, Katharine. What about TMS or some other neuromodulation?
Yeah, no data on TMS. I see quite a few people who've had it and haven't responded, but I'm sure there's some referral bias, right? Because if they'd done well, maybe they wouldn't be coming to see me, right, for a consultation or treatment. So, no data at all. Sort of my sense is not so sure it works that well for BDD, but we don't really know. And maybe deep TMS, or maybe sort of other targets that we might use for OCD. I mean, we need the studies.
Right.
And
we
don't have them.
Right. There is a small literature of TMS for OCD. That's where I was coming from. So,
yes.
As always, the answer is always we need more research.
We need more research.
We need more research, and I hope the government's listening. We need more funding to do more research.
We definitely do, especially for BDD because of the high rate of suicidality. It's really urgent from a public health perspective. Yeah. But medication often helps. Of course, we have to make sure people are taking it. As we know from other disorders, adherence is often quite poor across disorders. So, but patients really can get just so much better and often, go into full remission if we get the dose just right.
Sure. But I imagine that this is a disorder where cognitive behavioral therapy is absolutely indicated as well. Could you tell us a little bit about that?
Not necessarily for everyone, but I mean, I treat quite a few patients just with meds alone, but I think, I usually also recommend cognitive behavioral therapy. It's another great treatment. So these are our two first-line treatments. It does have to be tailored to BDD's unique symptoms, right? So treating BDD as if it's social anxiety disorder or OCD often doesn't go that well. We always do cognitive restructuring, and we do that before we do exposure and ritual prevention. And in OCD, we sometimes do cognitive therapy in addition to exposure and ritual prevention, but not always. But I think in BDD, it's really important because of the poor insight. And so we help them, learn to identify the negative thoughts that they're having that often just kind of fly through their head, and we help them recognize the negative thoughts, and we teach them about cognitive errors and to identify those errors and come up with more accurate and helpful beliefs. For example, I can't go to the party tonight. Everyone's going to be laughing at my nose. It's just so crooked. Well, there's fortune telling in there. There's mind reading. There's personalization. And I actually think everyone on the planet should learn cognitive therapy.
Yes,
we all make these cognitive errors, right?
I agree.
From time
Absolutely.
to time.
Absolutely.
About in all different kinds of situations. So I think that's very helpful. And then we move on to, gradually doing exposures, which are usually to social situations. We do behavioral experiments. We have them predict what they think is going to happen when they go out around people and make it very specific, and then come back and tell us what they learned. For example, 70% of people who are walking towards me on the sidewalk are going to look at me with at least a fleeting look of horror and cross over to the other side of the street because I look so bad. And we specify the 70% because if one person does it, they might think, see, people are, laughing at me and avoiding me when I go out. So And then we talk about what they learned and what happened, and gradually people become more comfortable in social situations. And then the ritual prevention is very much like we would do in CBT for OCD. It's very important. Those rituals are so toxic. They keep the BDD going, the mirror checking, the compulsive grooming, the skin picking, trying to make your skin look better, but can actually make it create actual lesions and scarring. And all of these behaviors just keep the preoccupations going. And so we help patients learn different ways of cutting back on those rituals and, so, hopefully stopping them altogether. And sometimes patients will decide to delete certain social media accounts, to bring us back to our earlier conversation, because they're doing so much comparing and looking for cosmetic treatments and what's the latest surgery for jaws and all this kind of thing. And so sometimes that will be an aspect of ritual prevention. We also do some perceptual/mirror retraining, because we know that people with BDD, when they look in the mirror, they tend to zero in on the thing they don't like. Their lips are uneven, or their neck is too wide, or whatever it is, and they hardly look at the rest of themselves. And so we help them learn to see themselves more holistically from head to toe. It's a very quick exercise. They just describe all of themselves in neutral terms from head to toe in about 5 minutes, helping them see all of themselves. And it's not staring in the mirror. I think that's a common error that's made. Sometimes people will do what's called mirror exposure, and they have people stare in the mirror, thinking they're going to become habituated to the anxiety they're experiencing. But no, and in fact, not checking the mirror is part of ritual prevention. We want people to stay out of the mirror as much as they can, and we don't want excessive checking. I also worry that if we have them stare in the mirror, that may even worsen the perceptual distortions that they already experience. I wonder if they're actually training their brain to become more sensitive to tiny, tiny things. So another thing we don't do is we don't do what we call extreme exposures, which you might do a variation of for OCD. Get someone's hands a little dirty out in the garden and don't wash them, right, for a few hours, that kind of thing. But we don't have people go out with very wild hairdos if they think their hair looks strange or they think they have terrible acne. We don't draw big red circles on their face and have them go out, because I think it's too distressing for most of them. And we don't want to do anything that embarrasses them. And in fact, and people might actually take special notice of them, right, if they look very odd. And with our exposures, we want people with BDD to learn that no one's noticing them, right? Not more than anyone else. And, they're not standing out in a deviant way. And so I would just caution against that kind of an approach.
Yeah, it's interesting. You're making me think about, we talk about neuroplasticity a lot and sometimes enhancing circuits and various things, and it can be good or bad. And it sounds like what you're saying, there's certain situations that may strengthen the pathologic circuit, if you will, strengthen those connections. Yeah.
Yes. And in fact, we know, we've learned so much in recent years about what's going on in the brains of people with BDD. And what we're learning, based on fMRI studies, studies on computers, psychophysical studies, et cetera, is that the brains of people with BDD are working too hard to see detail. When they're in an fMRI scanner looking at faces in the scanner, including very fuzzy faces with really no detail, their brains, compared to those of healthy controls, are trying to pull out the detail that isn't really even there. And you can see that part of the brain light up. You see hyperactivity compared to the brains of people without BDD. In addition, area of the brain that is specialized for what we call holistic visual processing, global visual processing, seeing the big picture, that part of the brain in back and occipital lobe is underactive. So details to them look huge and prominent, and because of the deficits in holistic visual processing, they can't contextualize the details and realize they're just details. Oh, so, okay, yes, maybe your nostrils are slightly uneven, right? But, to people with BDD, it looks really huge and obvious, and no one else would even notice it. But I think that these abnormalities in what they're actually seeing helps explain the poor and even absent insight that most patients have, thinking that they really do look abnormal or ugly in some way. And one study compared visual processing in BDD to patients with anorexia nervosa. And interestingly, there were some similarities and some differences, and the visual distortions in BDD were more severe than those in anorexia nervosa. So sometimes I think, wow, that kind of helps us understand how distorted their perception is and why you can't just talk them out of their belief. What do you mean you think your chin looks receded? You look fine. That does not help, right? You can't just talk people out of their how they're seeing themselves.
Well, of course, what you're describing is dysregulation of circuits, dysregulation of parts of the brain. It's sort of not too much, too little. It's kind of both. And what you're also describing to me that's fascinating is overlap with psychosis to some degree, delusions, if you will.
Yes.
And I know when I'm working with patients with schizophrenia, sometimes family members will say, well, can't you just tell them it's not real or talk them out of it? And I always say, no, I can't. To some degree, your perception is your reality.
Yes.
And so how do we confront some of those when we're working with our patients, some of those cognitive distortions and poor insight, if you will?
Yes. I of course always, like to provide quote unquote psychoeducation about the disorder. I think that's really important, and explain what BDD is and why I think they have it. And I do say a little bit about those visual processing studies, that their brains are too good at seeing details. They don't have brain damage. It's just parts of their brain are working too hard to see detail, and the parts that see the big picture so that details appear appropriately tiny are underactive, and that so that they are seeing themselves differently than other people see them. And, I know I can't talk them into that or convince them, but just so they're aware that, they're seeing themselves differently than others do. And I often see young adults or teens with the parents, and, they often get into arguments about how they look, how the person looks, or, with the partner. And, I think we just have to, I often ask, does it help when you try and convince your mother, that your teeth are crooked and too yellow? And the kid will say no. And I'll ask the mom, does it help if you say you have lovely teeth, they're perfectly straight? And they kind of both say, no, this doesn't work. And so I'll just say, you're each seeing him, you're seeing yourself differently than your mom is seeing you. And so she can't talk you into her view. You can't talk her into yours. I think you just have to agree to disagree for now. And, I think treatment can really help you learn to see yourself more accurately, and also obsess less about this and feel better and function better. And mood usually gets better, depression usually gets better, etc. But I do kind of put that piece in about the visual distortions. Just why not?
Well, no, I
try
think
and explain how it works and why people have different perspectives.
I think talking about
family members.
Yes, and I think talking about genetics and neuroimaging findings is extremely helpful.
Yes.
There's a lot of guilt, of course, and self-blame and all of these things. This isn't your fault, and that kind of thing.
Right. Yeah.
Okay, now, unfortunately,
definitely.
One of the consequences of this disorder is that patients insist on cosmetic procedures, as you mentioned earlier. How do we navigate that? How do we do that?
It's challenging. We know that about 3/4 of people with BDD seek cosmetic treatment, and about 2/3 actually receive it. Dermatologic being most common because skin and hair concerns are number 1 and number 2 in terms of body areas of concern, and maybe, fears of balding. And then followed by surgery and other types of cosmetic treatment. And as best we know, these treatments do not help. and can even make BDD worse. And it makes sense because the problem with BDD is not how the person looks, right? The flaws that they perceive by definition are minimal or only, slight. Not anything you'd notice when you first meet them, talk with them at conversational distance. And so changing a surface characteristic isn't going to change the tendency to see themselves in a distorted way and obsess about it. And we know that about 20 to 40% of patients after they have a cosmetic procedure switch to something else, right? So because, they have this tendency to, we all have a million things on ourselves that if we wanted, that were potential targets of worry, right? If we had BDD, then of course we could easily focus on something else and obsess about that. So, and occasionally, maybe 20% of cases, people do much worse after a cosmetic procedure. I especially worry about rhinoplasty. That might be the riskiest of all. And the nose is the third most common body area of concern in BDD. And conversely, studies indicate that maybe 20% of people seeking rhinoplasty have BDD. And the American Academy of Otolaryngology put out a practice guideline, on rhinoplasty practice guideline, saying that, it's contraindicated to do a rhinoplasty on a patient with BDD. So yes, like the strongest word we have in our field for don't do this, right? So I always tell people that, I can't predict with certainty how they will do with a procedure, a cosmetic procedure, but this is what we know about the outcome. And fewer than 5% of people find that they get better, that they are less concerned about the treated body areas, and they don't develop a new BDD concern or continue to be obsessed with other areas, because most people are concerned about more than one aspect of how they look. And, just encourage them to get treatment that we know usually works and is very low risk, which are the SSRIs and the CBT, and ask, are they willing to try that and the potential benefits? And for patients who still want to get the surgery or the cosmetic treatment, we ask, are they willing to delay it until after they get some good med trials? And maybe it will take more than one med trial, sometimes yes, sometimes no, and good CBT. And I find that most patients who get good psychiatric treatment end up not wanting the cosmetic procedures. I had a patient she was maybe in her 20s, and I think she'd had like 25 surgeries. It's unbelievable. And after she got medication, CBT, I followed her for a number of years. She didn't have any more. So that's, of course, the kind of outcome we'd love to see. But we do address it in our CBT treatment. If someone is receiving or planning to receive cosmetic treatment, we will address it directly with the CBT treatment, listing potential pros and cons of the treatment, doing some cognitive restructuring, trying to have them at least delay it until after they get good psychiatric treatment.
Yeah, I really like that concept of not, locking horns over should you get it or not and having us say don't get it. I kind of like the idea. How about if we put it off? I'm not saying yes or no until we try something else. This is an effective technique, I think. And it makes me think, too, about the concept in some other areas where we talk about, is my goal remission or is my goal harm reduction, so to speak? What's a reasonable way to think about
my goal is always remission.
Okay.
Yeah, because this is a very difficult disorder to live with. It causes enormous suffering, which is why I decided to focus my career on it. I think of all the patients I saw when I was a resident, these were among those who suffered the most, especially when it's very severe. And I just work very hard to get to remission or very close to that. Someone says, I'm thinking about it 15 minutes a day, and it causes mild distress. That sometimes is as far as we get, but I like to get it to no obsessions at all and no rituals. And I find if you get those medication doses right, and if you're willing to exceed those, sort of FDA manufacturer limits if you need to, but not for Celexa, not for clomipramine, right, as a tricyclic antidepressant. We achieve those doses by blood monitoring anyway, right? We check levels. But I find, people, those meds can help so much. And of course, the CBT teaches people wonderful skills. So I aim towards remission. I think if the patient is happy enough with very mild, minimal symptoms and doesn't want to make further changes in their treatment, of course, that's fine. But I think remission is often achievable. I did a relapse prevention trial with a colleague at Mass General, Sabina Wilhelm, where we treated 100 patients with escitalopram over 14 weeks, getting up to 30 milligrams a day, and then randomized half to continue on the medication, half to switch over to placebo. But in that, for 6 months. But in that acute phase, open label arm, we found that after 14 weeks, 25% on only 30 a day had achieved full remission. After 14 weeks and 30 a day of escitalopram, which, given that I sometimes go as high as 60, is not a super high dose, right? And then, some of them certainly did better if they weren't in full remission after they left the trial and went up to a higher dose. So, but I think in clinical practice, you can do much better than 25%. But, it usually takes a little bit of time to get there.
Sure. Well, I think there's an analogy here, too, again, with treating depression. I think too often people say good enough is good enough. And maybe our goal should be remission. And if we don't quite achieve it, we're going to get farther than if we say good enough is good enough.
Yes, I agree completely. And I like to track the symptoms, of course, by just asking the patient about their symptoms and how they're feeling. But I like to track it in the same way I track OCD, which is the first 3 items of the Y box and the BDD Y box. How much time per day would you estimate you're thinking about your appearance if you add up all the time you spend? So the time question. How distressing are the thoughts on a scale of not at all, mild, moderate, severe, and impairment in functioning on the same scale, mild, moderate, none, mild, moderate, severe, extreme. Extreme is the highest for both distress and impairment. And I just find that's a nice way to kind of track symptoms and see if you can get down to 0 for those 3, 3 items.
Well, getting back to a point we made earlier, too, about to be a good clinician is to be curious, it's also extremely important to define the exact target symptoms and, I guess, areas of body concern so you really know specifically what you're tracking.
Exactly, yes.
Yeah.
Yes.
I want to talk a little bit, of course, about any areas of emerging research or treatment. And one that I want to bring up is digital interventions are starting to be looked at in various other areas. What about here?
Yes. Well, my good colleague, Sabina Wilhelm, who I've done some CBT studies with for BDD, together published a therapist manual to treat BDD. So I just want to mention there are 2 evidence-based CBT manuals for therapists to use, used in good studies and shown to be, efficacious. So one is our treatment manual. Sabina Wilhelm is the first author, and then one by Weill, Veale, and Nezeroglu, 2 other BDD experts who published a treatment manual. So just so therapists are, aware that they exist. And then I mention that in part because Sabina Wilhelm has gone on to develop a digital CBT for patients. With BDD, of course, you have to screen patients carefully before that's recommended. Make sure they're not, highly suicidal or, have worrisome comorbidity or, and I'm not sure it's so appropriate for the more severely ill patients, but I think it's out and available. I can't say I know the exact name of it, but Sabina Wilhelm is the developer. So that is available. I'm sure there are lots of other things out there that are not evidence-based.
Well, there's apps that are unregulated, of course.
All kinds of apps, yeah. So I think that, has if it's used for the right patients, right? Those who aren't too severely ill. I'm not sure how well it works for those with no insight, who are so severely depressed. Are they even going to use an app? Those patients need a therapist, right? But I think for the right patients, maybe less severe BDD and not serious worrisome comorbidity, especially if they can't access a therapist, that can be a nice option. I think you asked about what's exciting on the horizon. Did you? Other things. Yes. Well, something I'm excited about is the question of, can we enhance holistic visual processing in BDD. So I do think sometimes the SRIs enable people to see themselves more accurately. I remember an early patient I treated came to me and said, "Did you know that Luvox makes hair grow?" I think
That's
sometimes
great.
some of them actually see themselves more accurately after good treatment with an SRI. And we do kind of a crude version of enhancing holistic visual processing with that mirror retraining I told you about, where we try and help patients see all of themselves from head to toe and not just zero in on the little thing they don't like their uneven eyes or something like that. But there are two studies that were done pretty recently. One, where the intent was to enhance holistic visual processing. Jamie Fusner did one of these studies. He's really a leader sort of in the visual processing deficits and abnormalities that are found in BDD. And he did neuromodulation with excitatory intermittent theta burst stimulation, ITBS, so like TMS, over lateral parietal areas. So over areas where dorsal visual stream, which is responsible for holistic visual processing, and he did this while patients were viewing faces. Now, it was a small study. It was only 14 patients, so preliminary. But compared to sham, ITBS enhanced connectivity in dorsal visual stream, those areas responsible for global holistic visual processing. He did see some improvement on a questionnaire of body image questionnaire. So, very small sample, and I'm sure he's going to do a bigger study. But that's really exciting, right? Might this turn, eventually be a treatment or an adjunctive treatment to meds and CBT? And then colleagues of mine and I, these colleagues are vision scientists, did something similar, although the methodology was very different. We trained, again, small sample of 19. We trained people with BDD and healthy controls on a computerized visual detection task, and that helped people see what we call low spatial frequency fuzzy faces better. And we trained them to see fuzzy faces better than high detail, compared to high detail or houses or faces, etc. And we found that training did significantly enhance detectability of these fuzzy faces. And on fMRI, activation for the fuzzy low spatial frequency faces increased in the BDD group compared to healthy controls, specifically in a face perception area that had previously been shown to have weaker activation during processing of low spatial frequency faces in BDD compared to control. So, both studies suggest that holistic visual processing of faces can be enhanced in people with BDD, one using ITBS, the other using a computerized task. But I think that's a really exciting area because, we need more treatments, of course, right? And we need even better treatment than we have. So I think this is really exciting work, and hopefully we'll learn more in the coming years.
Well, I completely agree. And it gets to what we were saying earlier about, fixing, if you will, or normalizing the neurobiology, maybe activating a part of the brain that's underactive, strengthening connections between parts of the brain. I love this. And again, there's an analogy with a lot of work being done in mood disorders, depression, and schizophrenia.
Right. Yes.
How about...
and look how far we've come from people just thinking it was BDD was vanity.
Oh, yes, of course.
Right?
Yes.
Yes. And so it's very exciting.
Yes. What about virtual reality? Anything there?
I don't know of any studies on virtual reality in BDD. What would you be thinking of? What might...
sort of
help, like for exposures.
Yeah, I guess it'd be the exposure.
Practicing exposures before you go out into the real world, maybe.
It's been used for PTSD and OCD, so I kind of was wondering. Yeah, it's a logic, but again, it takes money to support research, Katharine. So we need some money. Yeah.
takes a lot.
I can't believe how fast the time has passed, and I so appreciate your time. Yes, and I really hope, and I suspect our audience will find this very, very useful. But I don't want to leave without saying, and you do, I'm sure, a lot of speaking to clinicians. For clinicians listening, what would you suggest that they start doing tomorrow? How can they easily or quickly modify what they're doing in their practice?
That's a really great question. I would say look for BDD. Realize it's usually missed because patients are embarrassed or ashamed, or it's misdiagnosed as OCD or depression or social anxiety disorder. So I think it's especially important because of the high rates of suicidality. And the treatment is different than depression. And the CBT is different than for OCD or social anxiety disorder. So I would ask directly. I would ask, are you worried, that about how you look? Or if you want to normalize it a bit, some people are worried, about how they look. They think they don't look right or they look ugly. Is that a concern for you? And then, of course, we don't reassure them. What do you mean you look fine? Right?
No, yes.
That doesn't work.
Yes.
But you just ask them invite them to say a little bit more about it. And then you can ask, I like to ask, how much time do you spend each day thinking about this? If you add up all the time you spend, and we don't have a cut point written in stone, but like OCD, I think an hour a day or more is compatible with the diagnosis. And then we want to ask about, do these concerns cause clinically significant distress or impairment in functioning? And if they're a normal looking person, the quote unquote defect that they see is non-existent or only slight, and those diagnostic criteria are met. In addition to the rituals, that is part of the diagnostic criteria. Although I worry a little bit that sometimes we don't identify all the rituals, and then we might not we might not ask about the right things, or the patient may not volunteer it. So, but that's technically part of the definition. And then I think just definitely ask about suicidality, as we do for all patients, but I think especially these patients, it's very important. And keep in mind that we have great treatments, SSRIs, often at high doses like OCD, good cognitive behavioral therapy that needs to be targeted to BDD's unique symptoms. But most patients get better with these treatments. And I always recommend both of them for patients with severe illness, always. And we can certainly combine them for, mild or moderate BDD as well. So look for BDD. It's out there. Look for the clues, right? The rituals, the camouflaging. Do they have a baseball cap? We didn't talk about that. Do we have a baseball cap kind of pulled over their head, covering their eyebrows or their eyes or their forehead? Did they think their forehead's the wrong shape? If they're a guy wearing, the first person with muscle dysmorphia I ever saw, and nothing had been written about it, he was wearing six T-shirts. I could see the different layers. And I just asked him, because as psychiatrists, we get to ask these things, which we wouldn't ask someone at a cocktail party, for example. Like, I notice you're wearing, it looks like 6 T-shirts. I'm wondering why. And, he had muscle dysmorphia. He thought that his body was tiny and he was weak looking. And so he was trying to bulk himself up. So people are wearing big, heavy, like sweatshirts and hoodies, especially in the summer, hat covering their face, poor eye contact, heavy makeup. These are possible clues also to the presence of BDD. So yeah, look for it and you will definitely find it. And then most people get better with the right treatment. So it's just wonderful to find BDD when it's yes, there and try these treatments, because most people do get better.
Yes. And if I could make a suggestion too, perhaps familiarize yourself with some appropriate therapists in your area so that you can be ready to refer. And along those lines, Katharine, are there resources that people can learn more about this?
Yes, the website of the International OCD Foundation has a section on BDD. There's also the BDD Foundation in the UK. I haven't looked at their website in a long time, but you can look at that. I've written multiple books on BDD.
I know you have. You've published quite a bit.
Lots.
Yes, thank you for that.
Including one for. Oh, you're welcome. Yes, it's fun. It's a labor of love, but I've enjoyed doing it. And my most, I have an edited volume for clinicians published in 2017 by Oxford University Press. It's still pretty up to date, I would say. I also write for Up to Date, so I've written all their articles on BDD if you're interested in looking there. And a lot of people can access Up to Date for free, right, through their EMR or their institution. I've written some blogs on the IOCDF website, including ones about medication treatment of BDD. So those are some of the resources. Yeah, and I mentioned the 2 CBT treatment manuals that are available. Yeah.
Well, that's a lot. So thank you.
There's good information out there. Yes.
Exactly. And so again, our time has passed rather quickly. Unfortunately, we've run out of time. But boy, Katharine, I have learned a lot. I'm sure our audience has, and I really want to thank you again very much.
Well, thank you. It's been such a pleasure speaking with you, and I appreciate your bringing this really difficult disorder to the attention of so many people. I really appreciate that.
Well, certainly. And let me just tell the audience, for more information about NEI's educational offerings, our live meetings, virtual podcasts, you can go to our website, which is neiglobal.com. And for more of our podcasts, you can actually get these anywhere you get podcasts. You can search NEI Psychopharm, or my name is the host. If you search Cutler, you'll find this as well. So that's it for now. Please check out our other offerings. And Katharine, once again, thank you so much.
Thank you.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.